A warm good afternoon to one and all. Really, it is warm outside. So now we are going for an important panel discussion on peripartum cardiomyopathy. Say, what I feel, you may also might have seen, nowadays the peripartum cardiomyopathy incidence is increasing. A reason may be multifold. One, really the disease is increasing. Another one, our diagnosing capacity has increased. So we are coming across with a lot of cases on peripartum cardiomyopathy. Now in this panel discussion, we have Dr. E K Ramdas, Dr. Jerry Paul, and usually we will say a black sheep in the crowd, but now we are having a golden sheep in our crowd. That is a non-anesthesiologist, that too a much sought after specialty in the medicine. A cardiologist, Dr. Sunil Pisharadi, has come. He is from Perindalmanna itself. So I am happy that a cardiologist is finding time to attend non-commercial work, academic work, that too in the anesthesia area. So my special thanks to you, sir, because other two are my friends only. I need not thank him because in the home we cannot thank each other. So this odd man out and really a much needed man in peripartum cardiomyopathy, I love to have him here. Now the panel discussion, sir, it is going to go for 40 minutes. Anybody can take the question. In between, we will give a break for the audience also to ask their questions. So if it is going to be a rapid fire round, and if it is specific to the question, we can go for more questions. Or else if a reply is lengthier, we will restrict to minimal questions. Now, in the peripartum cardiomyopathy, first of all, myself as well as the postgraduates sitting on the back and the senior people sitting on the back pretending as if they are youngsters. The first question is, if it is a peripartum cardiomyopathy, we have so many cardiomyopathies. First of all, I want to know from the cardiologist, leave alone peripartum, sir. What is the definition of cardiomyopathy, sir?
Thank you for giving me an opportunity to talk and sit in a panel discussion of entirely different specialty of me, totally non-medicine actually. So it's very happy to be in the afternoon with all my senior colleagues, my friends and students here. And I attended at least 2 hours of most of the talks, and it is very, very difficult, tough subject, I think. And I think it's Sir has asked me, it's a pure cardiology subject, and so I have to discuss most of the time. I thought the panelists will be there and then we'll discuss each other. So it has to be entirely discussed. And Sir has correctly asked peripartum cardiomyopathy. What is the definition? See, peripartum cardiomyopathy is a very, for the decades, it has been known. Even 1840, it has been identified and reported. So in 1920, it has given a guidelines for the diagnosis, and it came as a separate entity. As far as our routine practice concerned, it is not so common in India actually, but by its diagnosis is by exclusion, so it may be more common. We don't know. Exact incidence is not there. And so who has put a definition? Is European Society of Cardiology in 2010 put a diagnosis, what criteria, and that is again followed by 2018 European Society of Cardiology. So there are 3 entities in the diagnosis. There is a symptomatic heart failure. The timing is very important. In pregnancy, during the last month of pregnancy or postpartum 5 months, in the initial 5 months. That is a timing. and no detectable cause for the peripartum for this cardiomyopathy has to be there, and an echo criteria. Echo, there should be a global LV hypokinesia with LV ejection fraction less than 45. So they want to exclude so many other causes of dyspnea and heart failure from this entity. So there are so many heart failures having an ejection fraction less than 25, an ejection fraction more than 50, which causes the heart failure. So they want to exclude all these sorts and basically come to an entity of peripartum cardiomyopathy.
That's it. Thank you very much, sir. So the definition is very clear for the audience. It should happen in the last month of pregnancy, but it can go up to 5 months postpartum. So that is the criteria. Why it had happened? Just to exclude other causes of cardiac failure, they have made the definition like this. It should happen on the last month because the pregnancy itself mimics heart failure. Now, just because the peripartum, anesthetists are also taking role in the delivery process, surgical delivery. Any one of the anesthetists can take this question. What will be the symptomatology if the peripartum cardiomyopathy occurs? Any one anesthetist I want to talk, because management cardiologist can talk. When you suspect, because obstetrician, immediately they will ask for anesthetist only whenever something happens, because they like to have a scapegoat. I think Mrs. Dr. Ramkumar Venkateshwaran is not here. That's it.
Yeah.
So she's standing.
Symptomatology.
My goodness.
Your question is symptomatology.
What is the symptomatology? If the peripartum cardiomyopathy occurs for the patient, what symptoms she will have?
Since most of the symptoms might mimic the symptoms of pregnancy. The third trimester, pregnant patient could have, mother could have breathlessness, and also sometimes they complain of fatigue. So that is, for that reason, sometimes it becomes difficult to diagnose postpartum cardiomyopathy. But then cough is an extra thing. A cough you may not get in a normal pregnancy. The patient having cough during the last trimester, orthopnea, paroxysmal nocturnal dyspnea, edema, of course, you find in pregnancy also. So some of the symptoms will point to the diagnosis of peripartum cardiomyopathy. And of course, the signs and symptoms of cardiac failure, like raised JVP, at least 2 centimeters above the clavicle in 45 degree sitting position, hepatomegaly and edema, all these would point towards the signs and symptoms of peripartum cardiomyopathy.
So, as a cardiologist, sir, what are all the clinical signs you expect so that you will go for echocardiography?
Yes, sir. See, whatever the symptoms he has mentioned, sir mentioned is very good. And because the pregnancy itself is a volume overload situation. So, a patient or a pregnant woman coming with a palpitation, increased heart rate, as well as the lower limb edema, and dyspnea on exertion. These are all commonly seen in most of the pregnant ladies. So this is why it has been delayed in getting the diagnosis. And what are the signs we can see? There will be a definite LVS3 will be there during auscultation. That points, and elevated JVP. That is a clinical sign. It's very important with the hepatojugular reflex. It's very difficult to elicit hepatojugular reflex, even though there will be a definite elevation of JVP. And there will be basal crepitations also there clinically. But clinically also, when the patient becomes very fat, very difficult to see I'm not mentioned the apex because most of the times in the pregnant woman, the apex identification is very difficult. So theoretical speaking, we can see the shift of the apex towards laterally. These are the clinical findings that we can see in a patient with heart failure.
You want to add anything?
Can. So most of the time, the patients are asymptomatic. So they usually undergo an uncomplicated anesthesia, like a spinal or an epidural or whatever. And then when they are evaluated for a persistently low blood pressure in the post-op, that's when many of them pick up this condition. Okay, so that's something we should always remember, because this is how I came across a case in my life. The patient was diagnosed only in the post-op. They did an echo because the patient had a persistent hypertension. They diagnosed it.
Now we will break for a question from the audience. With this only, if you have any clarification, you can ask before we proceed further. Anyone? Option is open, right? I think they have clarified you on definition and symptomatology. Now I want to know from sir, Dr. Jerry sir, I think you can keep the mic closer to your mouth or your mouth closer to the mic. So whether you can identify any risk factors in the preoperative period. If suppose normal delivery, obstetrician will conduct on her own. If the patient is coming for a cesarean section, can you look for any risk factors that the patient can land up in peripartum cardiomyopathy?
Yeah, it's basically elderly. That's one group of patients. And again, the elderly have the potential for developing a dilated cardiomyopathy. That's a different condition. So elderly come there. And then preeclampsia is another condition where they probably have a common etiology possibility, some of the... And a third situation is in this era of assisted reproduction, multiple gestation is another one. Okay, these are probable situations where cardiomyopathy might be seen.
So multiple gestation, multiple pregnancy, elderly pregnancy, PAH, we can add obesity, and nowadays, previously it was not there in India, now we can add alcoholism also. In the women, it can predispose. We can predict, but nothing is definite. Now I want to know from the cardiologist, sir, as it is a diastolic dysfunction, dilated cardiomyopathy in peripartum period, systolic function is mainly affected, grossly. Systolic function, that is the reason you mentioned ejection fraction is less than 45. So systolic function is affected, that is the reason why patient develops hypotension. Now I want to know, is there any pathology behind it? Then only we can treat peripartum cardiomyopathy. What is the suspected, any etiology or pathophysiology is there for this?
The pathology of peripartum cardiomyopathy as definite one cause is not identified. So there is no definite cause for it. But there are multiple theories that is proposed. One is because of the extra oxidative stress during pregnancy, the prolactin, which is not properly metabolized, and in the unmetabolized product, that is fully not metabolized product, prolactin fragments, that is 160 kilodalton, 145 kilodalton, prolactin fragments, that causes a myocardial damage. And there are other genetic etiologies are there, like that 7 genes have been identified that causes DCM, is also identified in the peripartum cardiomyopathy also. That's one way, common variant is TTN, truncated variants. That's not important in our situation because we don't send all these people for a genetic counsel, genetic testing and all that. That's in the Western population. And very important is the fetal proteins may enter into, that is immunological causes. There can be fetal proteins coming into the maternal blood and causing some autoimmune causes and causing the myocardial damage. See, another important thing, pregnancy is actually a stress test. So there is an increase in the cardiac output, more than 50%. During delivery, it is exceeding to 70%. And blood volume is increased to more than 50%. And there is a gradual shift of blood volume into the mother's blood, like extra release of catecholamines. These all contributed, this metabolic stress and the physical stress all contributes to the myocardial failures. And there are other angiogenic factors like VGF factors and other metabolites causing the pathology of peripartum cardiomyopathy. And one important thing they have done, due to the prolactin fragment over secretion, there have been studies, 2 or 3 studies, where they give bromocriptine to decrease the prolactin level in the mother. But one done in Africa as well as in Germany, both have given the bromocriptine of 2.5 milligram 2 times for 2 weeks and then extended to 6 weeks. This small study that is around, that includes only 21 patients, that shows some benefit to the mother as well as the fetus. In another important thing is bromocriptine, when are giving, it is a thrombogenic condition causing excessive embolization. So that's some of the etiologies. But when you go through the updates and all that, numerous causes for the pathological causes, but none is definite to the peripartum cardiomyopathy.
Thank you, sir. So there are so many etiologies that is not definite. So can we conclude that etiology is idiopathic?
No definite one cause. It can be idiopathic.
So it is idiopathic. What idiopathic means what? It is idiocy on the part of doctor, pathetic on the part of patient. That is idiopathic. So as things stands today, this peripartum cardiomyopathy, even etiology, pathophysiology, everything is idiopathic. So many theories are proposed. So even treatment is proposed based on the etiology only and the pathophysiology. So even they say there is a sarcomere mutation, and as Sar said, it is a prolactin problem. So it could be a vascular hormonal insult, but we are not definite about that.
Multifactorial. Then
Anyway, multifactorial means I want what is the etiology per se. Why I am asking? Multifactorial means we have to search everything. If it is idiopathic means even if we search, we may end up nowhere. That is the difference. See, you cannot screen for peripartum cardiomyopathy. You cannot prevent peripartum cardiomyopathy by any means. What I want to inform the entire audience, you will be sensitized on peripartum cardiomyopathy by these panelists. You are sensitized. If something goes wrong, usually in post-pregnancy, post-delivery, if something goes wrong, if the patient dies, the dustbin diagnosis will be amniotic fluid embolism. Now you can add peripartum cardiomyopathy also, because legally also you can argue it is a peripartum cardiomyopathy. And now luckily we have a good cardiologist who says the etiology is idiopathic, because sometimes the cardiologists say, no, you will diagnose, you can easily diagnose, you can treat. But now this diagnosis can also be used. It is out of box thinking. But as research develops, hope we will end up in a good treatment for this. Now, sir, Dr. Jerry, sir, what are all the complications that are possible if the patient develops peripartum cardiomyopathy?
One is they can go into overt cardiac failure. And these are the patients who generally have a lower ejection fraction, less than 30%, or the so-called fractional reduction diameter, less than 30%. Okay, that's one group, and they generally have a very bad prognosis. They either end up dead or on some sort of mechanical support or transplant. Okay. Then thromboembolism is another one. You know that pregnancy already, they are hypercoagulable, and on top of that, the treatment, the stasis of blood, all those things can contribute to thrombosis. Okay, so that's another thing. And the other deadly thing is the ventricular arrhythmia that they are prone for. Okay, so these are the reasons why somebody would land up in ICU or dead or all this.
Madam is here, obstetrician. Madam, Mrs. Ramkumar Venkateshwaran. Any opinion, madam, from your side, obstetrician, how many peripartum cardiomyopathies you have witnessed in your practice? You give the mic. Even though your voice is audible for me, others may have hard of hearing. Give the mic. Madam need not walk. Madam only can dance. Madam, Ramkumar is a good singer and you are a good dancer, madam.
Sir, I was searching for you because I wanted to say, not sorry, but I just have a loud voice. I didn't mean anything. Okay. So you are absolutely right that amniotic fluid embolism and maybe peripartum cardiomyopathy is a dustbin diagnosis. So instance of amniotic fluid embolism is 1 in 80,000, and I've seen seen one and heard of one. And peripartum cardiomyopathy, I've not seen here. I've heard of one in US. And when I was in St. John's, a young primee, post elective cesarean, no complications. I don't remember exactly what happened, but she collapsed and could not be extubated post surgery. So they diagnosed peripartum cardiomyopathy and they want to go to Narayan Hirdale because it's Narayan Hirdale. And I convinced the patient to stay back and the patient completely recovered. So I really don't know if it was peripartum cardiomyopathy. That's all I know about it. That's why I was waiting to listen. Your panels and lecture was really good, sir. And obviously, I'm not against the anesthetist because I love one.
Madam, you cannot be against the anesthetist. Then it will be against Ram Kumar. So, thank you. Usually, the obstetricians will seek the help of anesthetist only at the last. Because I have seen even in PAH, they will consult everyone, cardiologist, even ophthalmologist to examine the fundus. This pregnancy fundus they will examine, but ophthalmic fundus, then nephrology, everything they will ask, but they will never seek the opinion of anesthesiologist unless or otherwise the patient lands up in a cesarean section. So that is good. Madam is a good complementary to each other because she is a surgeon, he is an anesthetist. So, but she is dancing to the tunes of Ram Kumar. That is a nice thing to see because no wife will dance to the tunes of the husband. So she is an exception. So I congratulate that couple. So, sir, if you feel that the patient is developing arrhythmia and cardiac failure, everything, how you will be treating, sir, cardiologist?
Actually, I want to talk about the incidence also, because Sir has also mentioned. The incidence of peripartum cardiomyopathy is very, very low. Actually, it varies. It is prevalent in all over the world. But its prevalence incidence is very high in the Nigeria area called Saira, where the incidence is 1:100. So the black population is more prone, and very low incidence you can see in Japan, where 1:20,000. So what you, in your mind you will ask, what is incidence of here in India? There is one paper from South India where the incidence reported as 1 in 1,750 pregnancies. So I think we also, because I personally treated a few during my tenure at Peripartum, over the period of 12 years, I seen only 3 or 4 peripartum. Yes, definitely peripartum cardiomyopathy they see.
Yes, but sorry for the intervention. In that 4 cases, when the obstetrician or the anesthetist called you, suspecting on what parameters they have called you to give an opinion?
See, personally, I'm saying because when you get a postpartum patient, I usually give, in my unit, references to anesthetist, gynecologist, and the medicine, because it's a very complicated thing, one thing. And for managing the ICUs, anesthetists are far better.
Sir, one second. I'm not asking that, sir. See, in your 12 years of practice, you have seen 4 cases of peripartum cardiomyopathy.
Yes.
I am asking when you have called for that.
When we are called.
That is because you have given the opinion. You are the final diagnosis is done by you, peripartum cardiomyopathy.
No, actually, in our sector, the anesthesia is very studious. And they will always, the cardiac anesthetist is sitting in front of me.
No,
in our
I'm
hospital.
asking whether
when they are, whenever there is a dyspnea,
that's what I want.
That's
to know,
very important. Whenever there is a dyspnea, they will assess for the LV dysfunction.
Whenever there is a, then before you complete your this thing, sir, we will ask Dr. Ramdas, sir. Sir, what are all the probable causes you will think if the patient undergone cesarean section, delivered, that and all over, but in the postpartum period developing difficulty in dyspnea, breathing, dyspnea. What are all the causes you will think, sir? Then we will come back to cardiologist.
Okay. Again, it could be embolism, amniotic fluid embolism, or any other.
Postgraduates, please note, one could be embolism.
There is a second thing other than perioperative peripartum cardiomyopathy, and that could be cardiopathy not related to peripartum cardiomyopathy. Patient would have been having cardiac problems even before that. Because
So can we say that it could be occult mitral?
pardon?
Can it be occult mitral stenosis?
It could be, yes. It could be
Mitral
any valvular
stenosis may be
disease, any valvular.
undiagnosed.
But that we could elicit before patient is subjected to cesarean section. It's our delivery time. When you take the history, you definitely know the patient is already a patient of cardiac.
Sir, here I want to sensitize the youngsters. In pregnancy, there will be tachycardia. So the murmur may not be audible. And unbooked cases or cases treated somewhere else may end up in your institute for emergency cesarean section. So with the heart rate of 140, 142, we cannot identify MDM and we cannot ask the patient to undergo echo also. So you will immediately take the thing. And after the delivery of the baby, when the placental circulation is entering back into the systemic circulation, there will be a volume overload. And because of spinal anesthesia, we will be giving lot of fluid, thinking that it is going to avoid spinal hypotension. So there is every chance of developing pulmonary edema in occult mitral stenosis, I am saying. So postpartum difficulty in breathing, occult mitral stenosis should also be a differential diagnosis in addition to this. Sir, cardiologist, sir, you can carry on.
So the previously I talked about the incidence, and this difference in incidences may be due to the reporting the cases, reporting the methods cases. Sometimes in Africa and all that, they don't use the echo criteria. So there will be more dyspneas during pregnancy at the end of the pregnancy. So that will be taken as a peripartum cardiomyopathy. That may be the reason. And coming to the arrhythmias, what Sarah asked in between, it comes under the management of the heart failure. See, whenever there is a heart failure set in, we have to reduce the symptoms. So we have to give the diuretics. When there is a hypotension plus dyspnea, that's heart failure, we have to support it with inotropes. And whenever you treat with diuretics and the assisted ventilations, and you have to think about the arrest of the progression of the disease. So you have to add the other things like there are 4 or 5 drugs that is not indicated in pregnancy. That is ARB, ACE, SGLT2 inhibitors, and MRA, that is mineralocorticoid receptor antagonist, as well as the thing is RNA, that is sacubitril valsartan. Sacubitril valsartan is also not indicated. So the 5 drugs that is used to treat the cardiac failure in a common acute heart failures is not used to give in pregnancy. So just about the postpartum, then you can start on giving these drugs. So next is the arrhythmias. The arrhythmias are seen in the pregnancy related heart failure. It's around 16%, 16 to 20%. So around the VT, that is VT and VF comes around 5%. Atrial fibrillation comes around 10 to 12%. And the other sort of arrhythmias like SVTs and different arrhythmias are seen in these are all treated by antiarrhythmics. And the first thing we have to defibrillate and revert the ventricular fibrillation or VT into the sinus rhythm. So antiarrhythmics, the codron can be used. Amiodarone is usually used in reverting into the sinus rhythm. And if the hemodynamically stable. Usually in the hemodynamically stable patient, you don't get any arrhythmias in the sort of patients. And another important thing, when the patient is going for a hypotension, we have to give then the general anesthesia has to come in, and you have to be intubated and going for if is not supported by inotropes as well as the other medical management, we have to think about the supportive devices like ECMO, LVAD, and IABP. So that requires the major support from the anesthesia groups.
So, sir, before you top up that or you supplement that, you please add this answer to this question also. In what way anesthesiologist can help in the management of peripartum cardiomyopathy?
So if you permit me, I can take about 2 or 3 minutes to talk about a situation which I faced actually. This was a patient who got referred from another hospital. She underwent a cesarean, and then following cesarean, the patient had a persistent hypotension. Okay. And the anesthetist knew how to do an echo at that point, and that person picked up cardiomyopathy, informed the cardiologist, and had the patient referred to a hospital. Now, once they come to a hospital, because our ICU takes care of the obstetric patients requiring critical care, the patient was put in a bed there. Every day, cardiologist used to come twice a day and see the patient. The gynecologist will take rounds. Patient is stable. I see her having a breakfast, lunch, everything. She's smiling. So I keep asking my resident, when is this patient going to the ward? On the third day, she said, okay, tomorrow the patient is getting shifted. The next day when I come to the ICU, what I see is the sister is panicking. She's saying, I cannot feel the blood pressure. I cannot feel the pulse. So I go to the patient. What I see is a patient who's drowsy, arousable, but she's very, very tired, and she keeps asking for water. Okay? I check the blood pressure with the manual sphygmomanometer. The BP is only about 60 systolic, I cannot feel the diastolic at all. I managed to get an arterial line with the help of an ultrasound, and the BP is exactly 60. Okay. Now the cardiologist comes down, and he wants to start dobutamine to get the blood pressure up. So we have an argument. I say, there's no question of starting dobutamine at this point because the blood pressure is only so much. I wanted noradrenaline. And the argument went on, and finally I got the senior cardiologist to come down, and we started the patient on a small dose of NORAD, and the BP didn't change much, it just came up slightly. Now the ball is in my court. They want a tube put in. How do you do this in this patient? She's awake. How do you do that? You need to give some drug. Any drug that you give is going to depress the cardia or whatever, and she can go into a cardiac arrest. I need to speak to the bystander and tell them this is going to happen. And when I go to talk to them, they're saying that, see, we were never told. You were treating this patient for so many days. Why is she deteriorating now? See, that's the dilemma that we face at that point. Now, whatever it is, I decide to intubate. I get the permission, then I go give a 10 milligram of ketamine, some 30 mics of fentanyl, and suxamethonium, and intubate her. Okay. Now, the NORAD started in the peripheral line. I didn't put a central line on it. We didn't have time for that. Luckily, the BP did not even move. It just stayed at that level itself. And then I had this patient transferred to the CCU. And they managed at that point. Now, when the cardiologist showed me the echo at that point, when they were arguing, I could see that the heart was hardly moving. He actually had to point to a place and show me the heart moving. It was hardly moving. Okay, so that's the situation that we face. Right.
That's a situation where you have to put the IABP or the other situation. If the patient is not getting stabilized by inotropes, I think what Sarah said is correct, because don't start on dobutamine first because it lowers the BP again. And even though it is a...
Yeah, that is my question, sir. Sir, if suppose patient is having hypotension, the first responder is obstetrician. Then because cardiologist, he has to find time and he has to come, he is attending to many emergencies. Which inotrope you suggest before your arrival for the obstetrician and anesthetist?
Because inotropes, best thing is you have to start on phosphodiesterase inhibitors like milrinone, emrinone. If you want to get the cardiac contractility more.
That means the youngster should know the hospital should have the facility of availability of amrinone and milrinone.
Another important thing, see, we can start, it's a very good inotrope, dobutamine, but it does not increase the BP. It's a strong agonist of the beta-1 agonist. So whenever the patient is on beta blockers or some other blockers and this dobutamine doesn't work much. So we have to start on dopamine, definitely. Dopamine in a lower dose acts on the D1 receptor only. When it is in the higher dose, it acts on the alpha, beta, and beta-2. So in the higher dose, you will get a increase in the contractility, but at the same time, it increases the peripheral resistance. So in the heart failure, it doesn't much help, but only thing that we will get the increased BP, blood pressure. That's only a transient one. That's only for a bridge, for another bridging mechanism, like IABP or LVAD or ECMO.
So in the management for postgraduate exam purpose, peripartum cardiomyopathy management, it is going to be inotrope, ACE inhibitors, as sir said, it could be beta blockers, it can even end up in IABP. Sir, will it land up anywhere in cardiac transplantation?
Usually less than 1%, 1 to 2% only requires transplantation.
So you
And the
please
patient-
mark that also in the examination. Rarest of rare cases, that means the patient may not recover. So we will put an ancillary question to the cardiologist.
And
Sir,
that-
what is the outcome of this?
that
peripartum
transplantation itself, it doesn't do good, just like any other transplant patients in the general population for the DCM example, because there's a high rate of rejection, high rate of accelerated hypertension, and there is heart failure again.
So, sir, how many patients recover from this peripartum cardiomyopathy? That is within 2 weeks, or within 2 months, within 2 years, are going for a chronic failure status?
That's very important, because once you treat the heart failure in pregnancy, that is peripartum cardiomyopathy or any heart failure, in the case of peripartum cardiomyopathy, almost full recovery of LV function to almost a partial recovery of LV function in most of 70 patients, 70% of the patients. And in 50% of the patients, it will recover completely within 5 months to 5 years. So when you get a response, when you get a good response of the heart failure treatment, in 50% of the patients, you will have a full recovery of LV function in most of the studies. So by 5 years, almost 70% of the patients will have a full recovery, almost partial recovery. So that's very important, because what Sir has said is whether we have to continue the treatment of heart failure in peripartum cardiomyopathy once you have a normal LV function. That means the LV function becomes more than 50%. So that's a patient will also ask you whether we have to stop the treatment. Now everything is okay. That's very
Sir, then
important.
whether you will advise monthly echocardiography for the patient?
That Sir is very good, but maybe in some
Practical
of the
question.
but usually it requires only a 6 months interval follow-up
you.
of
Sir
echocardiography.
wants to add.
Just one point on dopamine. It has the ability to block the prolactin release. So that might be an advantage here. Okay. My first choice of inotrope on that day would have been dopamine, because we were not using dopamine for a long time. It has to be either a combination of NORAD plus dopamine. But you can't start this simultaneously. I want some kind of a constructive effect before I start dopamine, that one. Okay. So dopamine may have this theoretical advantage. It blocks the prolactin release. Okay.
But Sir said his first choice is amrinone or milrinone, inolatase.
Yes.
Sir, is there any drug by name cerilexin which competitively inhibits that relaxin 2 secreted by corpus luteum of the pregnancy? Cerilexin. Relaxin is the hormone secreted by corpus luteum during pregnancy.
Yes.
Even that is implicated in the pathophysiology of this PPCM.
See, actually the toxolytics agents that is given more than 4 weeks, and the beta agonist drugs has been implicated for a risk factor for the peripartum cardiomyopathy.
So once the patient recovers from PPCM, whether you will advise this ACE inhibitors or beta blockers for
See, I will consider two things, because we are following so many heart failure patients. Even after becoming a normal LV function, we have to still continue most of the treatments of ACE inhibitors, beta blockers, MRA. But in this peripartum cardiomyopathy, because it's a physiological phenomena, when the LV function is fully improved by 6 months, we can slowly taper off. First, mineralocorticoid receptor agonist, and then wait and watch. Every 2 to 3 months, we have to clinically observe whether the patient is going for a heart failure or not. And 6 monthly, we have to definitely do an echo and record that the LV function is more than 50%. And after that, after the steady state of at least 3 to 4 months, and then we can stop the AC inhibitor or ARB. And you can again follow up for again 6 months. And then you can stop the beta blockers also. So we have to observe the same patient for at least 2 years with a definite echo on these patients, at least 6 monthly, followed by you can follow up these patients clinically, at least follow for 2 years. The main important thing is there can be recurrence other than the pregnancy. There are some other causes causing these patients going for the LV dysfunction.
You want to add anything, sir?
See, it's very important that the patient's bystander know what to expect. Okay, in our patient, nothing was explained to the patient, and when this happened, they just went wild. Okay, so and then after that, because I was the only person who communicated with the patient, that man had my confidence. So even after, when they were about getting discharged or anything, they came and spoke to me and said, "Sir, please inform the other specialties that they should have told us all these things." So that's very, very important. Communicating and telling that this patient is not going to recover quickly just because of a treatment. We're just observing and supporting the patient. Things can go bad. That should be clearly communicated.
Another important thing is, Sarah's not mentioned, because if I treated a patient and seeing after 6 months the patient is getting the normal LV function, so definitely our people will go into a second opinion. And they will do again an echo. Echo is completely normal. And so why can't we stop all these medicines? They will have an opinion sometimes. So in that situation, there can be a lost follow-up and doing a very good, very, very high chance of them getting us back as a heart failure patients.
So as the time is over, I am giving a golden opportunity because I am going to ask $1 million question to all the 3 panelists. So now the choice is open for the audience. You can exploit that chance. Whether you have any doubt, yes, Dr. Suresh. Yesterday, I have quoted his name as Suresh Rao because my friend in Chennai, instead of Suresh Nair, lot of opposition from Kerala. Many people are asking how you can say he is Suresh Rao, he is Suresh Nair, right? Dr. Suresh Nair, I stand corrected. Really, I am standing corrected.
Thank you. And I had 3 cases of postpartum peripartum cardiomyopathy in the last 3 years, because we get involved with these patients very early as we look after the critical care also. 2 of these patients, now first thing I want to tell is my choice of vasopressor inotrope choice. The first choice will be levosimendan. Primarily the reason being that it does not cause tachycardia.
What is the choice?
Levosimendan. Because Milnon will cause tachycardia and probably push the patient into atrial fibrillation. The second choice, I would add, although not the best choice, I add a very small dose, 0.04 or 0.06 microgram per kg per minute of adrenaline, just to increase the inotropic effect. And third thing is, if BP drops, I will add a small dose of vasopressin. Now, I will not wait for things get worse. Our first choice is either an IABP or ECMO. We have had 3 cases in the last 2 years. 2 of them we could put on ECMO and save the patient. The third patient, we just put an IABP and the patient became okay. So my choice of drugs in these patients, and most of these patients recovered within 7 days. ECMO run was only for 7 days, both the patients. IABP we removed on the 5th day as usual.
That is a good. So postgraduate should add levosimendan and vasopressin in the management in addition to amrinone, milrinone. Then your dopamine, last comes dobutamine, which they are reluctant in using. Any other supplementation or clarification? Juniors are not coming forward. So I think it is very clear. If a PPCM is asked in the university question, then they will answer very nicely. Now I am going to ask $1 million question. We are winding up with that. Sir, if suppose the patient has recovered completely from the first pregnancy, first peripartum cardiomyopathy, will you advise subsequent pregnancy?
That's most of the study data about this peripartum cardiomyopathy. There is a high chance of getting a recurrence of the LV heart failure symptoms in the patients having an LV function that's not fully recovered. When the patient is fully recovered LV, there is also a chance of around less than 10% chance of getting a recurrence So we should advise the females having had a history of peripartum cardiomyopathy to avoid the further
Sir, only one
pregnancies.
child, sir. You will not allow second pregnancy also.
You can take a 10%.
Obstetrician, madam. Obstetrician, madam.
You can take a 10% risk.
Whether obstetrician allows it or not, the patient will beg the obstetrician, please allow me, madam. Whether you will allow, madam? Yes or no? You are not for it. Madam, you will be losing a case then. See, she will be coming once in 2 days. You can monitor the patient every alternate day.
So the modern way of answering is give informed consent and give her the choice. That's what the modern student would answer.
That is a good answer, informed consent. Sir, now, if the patient is adamant that it has to go for a second pregnancy, second child, because second child is not a luxury. It is needed also. Second, the patient lands up for elective cesarean section. That's what usually people will do. Whenever there is a problem, we will do elective cesarean section. What precautions you will take, sir? Ramdas, sir. You can get his mic. Seek cardiologist opinion, sir, in getting the mic.
Yeah, when we talk about management, we usually talk about the cardiac grid, the preload, the afterload, the contractility. So the preload has to be optimized. Not too much of fluids. So preloading before spinal anesthetic is not permitted.
So you have decided anesthesia is spinal. Oh, that's right.
That again depends on whether it is a decompensated heart or a compensated heart. So if it's a compensated heart.
No, it is normal, sir. Normally only they are landing.
So,
then only problem starts.
Then I will.
If they are coming with the problem, we have an advantage. We can label it in the case sheet. Then we can do whatever we like. But the problem is patient is walking in normally, then develop peripartum cardiomyopathy. And the patient says because of your spinal anesthesia only peripartum cardiomyopathy occurred. That is the problem. So your precaution will be optimize preload.
Yes, afterload.
Madam wants a preoperative echo. That is a good one. Madam wants a preoperative echocardiography just to get trapped. Because preoperative echo will be normal. Post-operatively, it will be affected. That is right. That is true also. But anyway, for completion's sake, because the judges may not be knowing the intricacies of the subject, so they will ask you, the patient has developed peripartum cardiomyopathy, why have not undergone echocardiography? And now, just because madam has said echocardiography, sir, I want whether you feel cardiologist, not as a cardiologist perspective, but in the general perspective, whether echocardiography is mandatory for all parturient females. No, not required. That's it. So you are a good cardiologist. So even if you are losing your practice, you are saying scientifically. So this echocardiogram, most of the times, majority of the obstetricians, thinking that they are helping the patient or for medico-legal purposes, routinely they are sending the patient for echocardiography. That is not mandated. So you will take only that. What precaution you will take, sir, if the patient lands up for subsequent pregnancy cesarean section?
If they land on table, I have nothing else to do other than give a spinal and take care of it. I may, again, because it's easier for me to start a small dose of NORAD so that I prevent a sudden drop in blood pressure at that point. Okay. So I might put an arterial line if I need to give
you'll
spinal.
put the arterial line.
Definitely. I'll put an arterial line if I know that this patient has got cardiomyopathy. Okay. The second thing is I might start a small dose of NORAD in the peripheral line and then give a spinal.
Sir, 1 minute. What is the idea of putting an arterial line, sir?
No, that's just to give a little confidence to you that the blood pressure is being...
See, confidence for the doctor, sir. But I think it is on the patient side. It is not accepted. Because for a cesarean section, how we can sacrifice one radial artery?
Yes, sir. It's something that...
Anyway, that is your choice. So,
times have changed.
Obstetricians referring patients for anesthesia to Dr. Jerry Paul, the patient should be prepared to lose one radial artery or radial artery monitoring. That is nice. It is individual preference. Madam? Oh, immediately you take it out, right? Anyway, so the anesthesia management differs from anesthetist to anesthetist. So the anesthesiology, there is no safe anesthesiology technique. Every technique is having a problem. So we are having safe anesthesiologist. So whether your anesthesia technique is spinal, epidural, or whatever it is, just like swimming, whether it is a breaststroke or reverse stroke or backstroke, our idea is to reach the shore safely. So whatever may be your anesthesia technique in PPCM, safe anesthesiologist is mandatory. Thanks for patient hearing. Thank you.